get started this morning. And so we will, first of all, address the answers to the quiz from yesterday afternoon. So Aiden is putting those up. And so the first question is patients with a polymorphism of which enzyme would not be placed on lithium or should not be placed on lithium? And the correct answer is D, none of the above, because remember, lithium is not metabolized through the liver. And the 2D6 and 3A4 are primarily the two main enzymes that metabolize drugs through the liver. So polymorphism really wouldn't affect the effects of lithium. So the correct answer is D as in dog. Question number 2, loss of efficacy with carbamazepine after long-term use is related to, and the correct answer is A, enzyme induction. We covered this just before we are at the end of the day yesterday, and one of the things that carbamazepine does is it will induce its own metabolism. Once that it is, we run into this not only with it used as a mood stabilizer, but we run into it when it's being used as an anticonvulsant. So the correct answer there is A, enzyme induction. And question number 3, which drug is structurally related to tricyclic antidepressants? And that is C as in Charlie, carbamazepine. So lithium and valproate are structurally unrelated to the tricyclics. So that sort of brings us to, we're going to pick up today, and what we're going to do is we're going to, probably this morning, we're going to talk a little bit more about the different drugs. And probably at our first break, I'm going to give you just a few minutes more. Hopefully you were able to look over the case study that I sent yesterday. And so we'll take just a little bit longer break at the beginning and get your feel for what you guys would do in treating this patient. And then I'm going to throw a little bit of a wrinkle on your case study to see how you respond there. So what we'll do is we'll talk about the case study. Then what we're going to do is we're going to have you address the wrinkle where the patient comes in, and after you've basically come up with a plan how the patient can mess you up just a little bit and see how you respond to that. Okay? All right. So let's get started here. And we had finished up yesterday going over the mechanism of action of carbamazepine. And so we're going to continue talking a little bit more about some of the side effects and various other aspects of carbamazepine. So when we are dosing with carbamazepine, and typically when we have some of these things when it wants you to take it with meals or whatever, typically what we're going to have is the pharmacy is going to put a label on there that is going to say you should take with meals. And what we do see is with carbamazepine is that, if my slides will quit jumping on me, what we typically see is patients will sometimes complain of GI side effects, some nausea, vomiting, or really sort of nausea and maybe some bloating. And we find that by taking it with meals, that seems to help. So if GI side effects seem to be the main thing, by usually having them take it with food, that will help quite a bit. Now, sometimes people, just so that you know, is when you say take it with food, people sometimes will go, okay, I'm going to grab a little bite. So they grab a couple of crackers and eat it. And some people will like, okay, I'll take it, with my meal, which is what a lot of people do. But sometimes, people may not eat enough, and so they may still get a little nauseous. So you may just ask them. So I've seen patients that sometimes it's like when you say take with food, they'll grab a couple of Ritz crackers or a couple of, these Captain's Wafers and take those and then take the pill. And again, then they say it doesn't really help. May need a little bit more food than that. Typically when we're dosing, and again, just to reemphasize, I'm not going to ask you doses. The only numbers that you will need to know is going to be the lithium toxic values and the therapeutic range, but which we talked about yesterday. But basically what we typically will do is with acute mania, we'll usually start somewhere between 200 to 400 milligrams per day. And then about every 3 to 5 days, we'll increase it by about 200 milligrams. Typically, we're going to give it 2 to 4 times a day. Um, and if we don't see a response in about 2 weeks, what we may want to do is look and measure plasma values. So typically what we're going to see is that we want to make sure that the doses that we're giving is that the individual's plasma values should be somewhere between 6 to 12 micrograms per milliliter. And again, don't worry about memorizing that. Those are things you can look up. Sometimes we may go up as high as 14 micrograms per mil, and that occurs sometimes in treatment-resistant patients. But one of the things that if we get them to where they seem to be symptom-free, we can increase the dose and go up to around 6 to 1200 milligrams per day. So notice, just as a point, that the dosage is in milligrams and the plasma or serum levels are in micrograms. Typically with kids, we're not going to want to go, when we use children, there's a big thing in children. In this case, with the dosing, they will usually say under 15. We tend to want to keep them under a gram per day. If they're older than 15, we may go a little bit higher to 1.2. But again, we're going to keep them lower. And one of the things is, as we mentioned briefly yesterday, is that that a lot of times we may start off with monotherapy, but many times we're going to be using combination therapy. Again, I want to emphasize that we are clearly talking combination therapy, not polypharmacy. Combination therapy is going to be a rational combination of drugs, whereas polypharmacy is where that we are just basically piling on drugs, or a lot of times polypharmacy may occur when patients may specifically have multiple treaters, or a treater is adding drugs and not taking off the other drugs. But if we're going to use lithium, valproic acid, or other antipsychotics in addition to it, typically we're going to use a little lower dose. One of the things that we're going to do is carbamazepine. Any of the anticonvulsants, there's the general statement of that if you're going to remove the drug, to remove it slowly. If it's being used as an anticonvulsant, you want to make sure that it doesn't precipitate, basically lose the protection and they have seizures. But as we start dropping dosages, we're going to withdraw. We're going to want to see if the manic symptoms come back. Typically, one of the reasons we're trying to keep the dose down really comes down to the patients complain a lot of times of drowsiness and dizziness, and this can have an impact on their ability to function during the day. So typically, if we're at too high dose or we try to increase it too quickly, most of the time what the patients will do is they will complain of severe drowsiness and or dizziness. If you're prescribing this and a patient is driving, you may want to tell them to be aware that it could affect their driving and to see how it's affecting them before they're really driving. Like a lot of drugs, like most drugs, pretty much we don't have a direct relationship between the dose and the plasma concentration. Especially with a drug like carbamazepine, one of the things that what can happen is basically enzyme induction can occur. So a dose may actually have a decreased response. So what these plasma concentrations are, when we're looking at them, primarily what we're doing with plasma concentrations is that that is what we should be in the therapeutic range if we're in that range. That doesn't mean that we should be having a response, but most people, if they're in the therapeutic range, then we should be seeing some response. So you can't correlate a plasma concentration with either an anti-manic or an antidepressant effect. Literally, what the plasma concentration will tell you is basically that the dose that you're giving is getting them within the normal therapeutic range. And most clinicians typically will take 6 to 12. That's where they target it being somewhere between 6 to 12 micrograms per mil. but if the patient is being resistant, they may go up a little bit higher. The enzyme induction, if it's going to occur, typically will occur by a few weeks, usually 3 weeks to a month. So when what we may see is that we're giving them a dose, but our plasma concentration may be lower than what we anticipate. So we may start off at 6 to 12 micrograms, and what we may be seeing is that plasma concentration decreases. One of the big things that you have to consider when you're dosing these patients is, again, we can have enzyme induction if they're taking the dose or taking their drug correctly. But the other thing that can happen is we have to, again, think about compliance. So one of the issues that could occur is that we may not be getting those plasma concentrations because the patient may not be taking their dose. Sometimes patients don't want to take the drug, as we talked about yesterday. Sometimes patients, they may consider it expensive and they may not think they need it. So they may start changing their dosing to every other day, or maybe only taking 1 dose a day. So it's important before we alter the concentrations or to alter the dose that we understand, is it an enzyme induction thing, or is it a compliance issue? If we think it's enzyme induction and we increase the dose to account for the enzyme induction, but it's actually a compliance issue, we can move them into toxicity. Now, there is a black box with carbamazepine. And one of the big things, and a lot of these anticonvulsants, several of the anticonvulsants have this. So the black box is basically warns of serious dermatological reactions. And that has been associated with a specific allele, specific genetic issue, okay? And this is HLA-B1502. We know that patients with Chinese ancestry, that we know that there is some of the groups, Chinese groups, that may have this. And so a patient with Chinese ancestry should be screened for this allele prior to initiating therapy. If they have this allele, carbamazepine may be contraindicated. I have seen patients been put on this when they've had this allele. They need to be monitored carefully, but most people will go to a different drug. And this is both whether it's being used as an anticonvulsant or whether it's being used as a mood stabilizer. But we can get this screening. The screening can be done. It is available. And if there is any hint of Chinese ancestry, they recommend that you screen to see if they have it. People with this HLA-B1502 are very, very, very susceptible to the development of things like, and when we talk about serious dermatological reactions, we're talking about Stevens-Johnson syndrome and toxic epidermal necrolysis. So those can be life-threatening, but even if they're not life-threatening, they are very serious diseases that can produce some significant morbidity. Another concern that we worry about is, and the black box deals with aplastic anemia and agranulocytosis. What we find is that patients on carbamazepine have an increased risk, and the black box, I think, gives 5 to 8 times greater risk of developing aplastic anemia and agranulocytosis. So what we suggest is, before putting them on this drug, is that we do a baseline hematological testing. What are we going to request? What lab test are we going to request? CBC, correct. So typically we're going to do, as far as with the aplastic anemia and granulocytosis, CBC will give us what we need. But you're going to also look at, you're going to want to do a metabolic panel on these patients. So, but definitely a CBC to see if there's an issue. That gives us a baseline. It also would tell us if there's any pre-existing hematological abnormality. That's important because if we wait till after the drug is given, then we would assume that the drug did it, but we may have something else going on. So we get a baseline CBC. So if we're going in basically, typically with this, we're going to get a metabolic panel, a CBC, probably a thyroid, get weight, body weight will be measured. The other thing is, if we suspect that there's Chinese ancestry, then we would request the allele assessment. So when we start testing them, we're going to monitor through testing. We're going to do two things. One is going to be just simple monitoring when you see the patient, asking them, are they having any, issues. So from a clinical standpoint, without the labs, what questions or what things are you going to look for that may potentially assume or may potentially signal that there may be some sort of hematological issue going on? Okay. So from a hematological situation, what you're going to look for clinically, symptom-wise, is fatigue, tired. Sometimes they will say, I just don't seem like I'm getting, getting rested or something like that. But typically fatigue, that's typical signs of anemia. Pallor, they look real pale. Other thing is bruising. One of the things that you're going to see is if there's a platelet issue, you're going to see bruising. One other thing may be is a person may say, I seem to be just getting sick all the time. So I seem to be getting these colds, or sometimes they may talk about, for example, some, we all get cuts and scrapes and scratches, and they may talk about it seems to get infected. So what you're looking for really is, you've got three different major classes of blood elements. You've got the red blood cells. They would be tired, maybe sort of washed out. Sometimes if you were taking they may be tachycardic. They may talk about their heart beating faster. The reason that occurs is because the heart's trying to compensate because there's not enough oxygen, so the heart's working harder. So that would give us an idea if there's some red blood cells, maybe some RBCs. The bruising, or somebody talks about, I got a scratch on my arm that just seems to constantly bleed. So bruising and wounds that seem to weep. In a severe case, we might see somebody having nosebleeds or complaining of nosebleeds or bleeding around their gums, or even some rectal bleeding. That would be suggestive there's a platelet issue. And then white blood cells, pretty much you would see people may be susceptible to a lot of infections. They just seem to be getting sick all the time. So those are the clinical signs that we would be looking for, from somebody. So any excessive bleeding, any fatigue, things like that. And then we're going to monitor them pretty routinely through therapy. Okay. If we have any signs, so these CBCs come back with abnormal values, pretty much you are going to probably discontinue carbamazepine. What we hope to do is we try to catch if there's any aplastic anemia or granulocytosis that's occurring. We hope to catch it very, very early so that it might be reversible. Now, if you get something back with CBC, they may want to do some additional blood workup to see, if they look at different cells and things like that, it can give you a picture. But typically a CBC and some clinical symptoms would be a good evidence that you've got something going on here. So make sure you get a baseline, and then we're going to monitor throughout the therapy. Definitely if we change dosages, we want to monitor shortly after changes in dosages, but it's something we want to be aware of. Now, the side effects, there's several with carbamazepine that you just need to be aware of. A large number of patients, it's estimated around 60%, describe some sort of central nervous system toxicity. Now, keep in mind that when we're talking about these patients, when you're talking about the side effects to carbamazepine, this can include patients that may be getting this as an anticonvulsant, not necessarily as a mood stabilizer. But the most common things that we see is probably, let's go back here. My computer is being really sensitive this morning. The most common of things typically people will complain, they're sleepy or drowsy, dizziness, fatigue. We've also seen sometimes they feel like they're a little bit more clumsy, may have difficulty walking, vertigo, some blurred vision. If you were to examine them, you could see some nystagmus. The eyes are sort of jerking a little bit, confusion. But a lot of times the neurological symptoms we primarily see really come into sort of drowsiness, dizziness, and fatigue. Frequently, this is going to occur during the first few weeks of therapy. Typically, if the plasma level is below 4, we're not going to see them. But once we get up to 4, and remember, we're going to be targeting somewhere between 6 to 12 generally. So this usually is occurring when we first start. Now, again, the old adage of start slow and go slow, start low and go slow will work. So a lot of times by keeping the dosages lower, and trying to keep minimal dosages so that you're getting clinical effect, that works. Sometimes when people come in, what we see is a person is in acute mania and they try to hit them with high dosages. And so then we see some of this. The other thing we do is that, especially when starting off therapy, is if we can, give the main dose in the evening, right before bedtime. So that may help them sleep, and they're not up moving around, so the dizziness and fatigue may not be as apparent. Arnold, you ask a good question, is how do you distinguish bruising and bleeding caused by blood thinners? If they're on blood thinners, you're not going to be able to distinguish between, is it carbamazepine or if it is the blood thinner. That's one of those things. If you do see bruising and they are on a blood thinner, then basically probably most likely that is going to be due to the blood thinner. But think about this too, is that if they're on a blood thinner, that somebody should be monitoring their platelets and monitoring their blood. So you may have two eyes going there that may be helpful there, but there's nothing specific. So the only thing you could do is, let's say they were on blood thinners and were being pretty stable and wasn't having extensive bruising, and then you start them on carbamazepine and the bruising seems to get worse. That would be the only way. So it would just be really an issue where it seems to worsen with the carbamazepine. The GI things, as we said earlier, this occurs in, a lot of people suggest about 10 to 15% of the patients. Many times this can be overcome by administering with food, but typically, or the other thing you can do is sometimes reduce the daily dosage. But again, sometimes if we're at the lowest dose, then food will help. Then people will pretty much, the nausea is a common complaint. Abdominal pain, we can get diarrhea, constipation, and sometimes anorexia. The anorexia, think about this, is that if a person's nauseous, they're not going to really want to eat. So that's an issue that comes into play there. Let me follow up with, let's say, so with Arnold, the big thing is that on the blood thinners is that sometimes you can get, so the fatigue and the headache and clumsiness may be more of a loss of red blood cells. So they should be probably checking to see if your red blood cells are up there. Some of the blood thinners can cause that, but usually it's secondary to that. And that usually occurs fairly early in therapy. But the fatigue, clumsiness, and headache typically is due to a reduction in red blood cells. So one of the questions would be is that if your red blood cells, I would check to see if those were normal and that your hemoglobin is normal. That would be most likely what you would look for. Sometimes you can get some bleeding that may be occurring that's a slow scheduled bleed, or it's not scheduled, slow consistent bleed, and you can become anemic in that way. So again, the best thing to do would be when they do a CBC is specifically look at your red blood cells as well as looking for your hemoglobin. Now, one of the big things with carbamazepine that I want you guys to be aware of, and I'm sensitive to this because I've done a number of cases with Stevens Johnson legally, and I've served as a plaintiff's expert for these. Both I've done drug company and I've done against drug companies, and I've done med mal cases with that. We do see the carbamazepine, as with any of the anticonvulsants, that people will develop various dermatological symptoms. One of the things is that it's estimated that up to 15% of patients will have some sort of reaction or hypersensitivity reaction. Sometimes these are just red, itchy rashes. So these are pruritic erythematous rashes. You may get some hives, some urticaria. We may see a lupus syndrome, that lupus-like syndrome that may emerge. But again, our biggest concern here is SJS, which is the one of the things that we have to look at is that when Stevens-Johnson syndrome is starting to develop, it starts off a lot of times with the rashes and things like that. So when a rash develops, one of the things we want to be is very cognizant of that. We want our patients to tell us. We want to make sure is that the patient starts complaining of blistering rashes. We starts getting some involvement of the eyes, the mouth, the mucous membranes. Those are very common emerging symptoms of Stevens-Johnson. And I think I've given you all a paper. Have I given you guys a paper back when we talked about pathophysiology about SJS and TEN? If not, I will give you guys a paper for that, a good reference for that. So what I'll do is I'll pull it up anyway and give it to you. So if you can't lay your hands on it, I'll send you one, a couple of papers on Stevens-Johnson. So when you get to Stevens-Johnson, and we'll talk about it a little bit later on today, too, is that Stevens-Johnson is when you typically have under 10% of the body surface area that is involved. When it goes to the severe toxic epidermal necrolysis, we refer to that as TEN, T-E-N. Then you've got over 30% of the body area. Many of the cases that I've worked on as an expert, we've had skin involvement well over 30%, many times up to 90% involvement, and these are equivalent to third-degree burns. And this can progress, but we do know if you stop the drug that the prognosis is much better. And so there is an important aspect there. But anticonvulsants are one of those drugs classes that typically has these type of things. Now, another side effect of carbamazepine is hyponatremia. This is often referred to as water toxicity. What happens here is that literally you dilute out your sodium. And when we find the way we address it as hyponatremic is we start seeing with serum sodium levels. So if they really start containing of being really, really tired or irritable, these are some of the first signs of hyponatremia. And there's a few drugs, some of you may be aware of the hyponatremia. If you remember 3, 4, 5 years ago, there was a radio station that had a contest that to see who could drink the most water. And their thoughts were, it's water. How does it hurt anybody? So there was a lady that actually drank so much water that she developed water toxicity. And I believe she did die. She literally, what happens by drinking so much water is she flushed out and diluted the sodium out, and she had seizures and died. I'm pretty sure she did die. So there's a few drugs that can cause this. Carbamazepine is one. And so if it's not bad to, if you're getting side effects, to easily request serum electrolytes. Those are fairly easy to get. As we've mentioned, there are some hematological side effects. They're rare, but you've got an increased risk if you're on these drugs. And the two things we see is an aplastic anemia and a thrombocytopenia. So the thrombocytopenia is where we get the bleeding. Thrombocytopenia is where we get the decreased platelets. So, but this can affect all blood cells. It can affect red blood cells, white blood cells, or platelets. So if we see any evidence of this occurring, we think it may be due to the drug, we should discontinue therapy. When you're looking at people on carbamazepine, we have seen that they can typically, the liver enzymes may slightly increase. So we want to be very careful. A lot of times it'll start going up, and many times it doesn't go past normal, but we want to just be careful of that, and especially if the person may have some ongoing other diseases that could be affecting their liver. We do know that it, as far as its effects in pregnant women, if you look at the scenario, it's one of those things where I was checking to see with Hippocrates what their update is. We do know it will enter breast milk, and and being a drug that is that can go there. So basically, with the new thing, they prefer patients to enroll in a. This is for patients really set up for people being treated for epilepsy. They do want to do that, but they recommend using contraception during treatment. And they also mention about that it can cross the blood-brain barrier. So if we can avoid it, again, it's a benefit-risk assessment. The best thing is to try to avoid pregnancy and breastfeed, and when breastfeeding. Few drug interactions. Lithium is combined with carbamazepine. From a therapeutic standpoint, they seem to have a synergistic effect, which means that it's more than just the additive effects. But what you see is, so from a positive thing, what we see is the carbamazepine potentiates the anti-manic effect. And we also see that the lithium, and it also, the carbamazepine potentiates the antimania and the antidepressant actions of lithium. Somehow that needs to be taken out. So that can augment it. Remember, the lithium seems to be more of an anti-manic, but it has variable. The biggest concern, so there is a reason, is because the combination of the two improves the anti-manic and the antidepressant actions. We worry about neurotoxicity, and again, this is not an interaction in the liver. This is going to interact in the due to it's a pharmacodynamic interaction. So neurotoxicity is a concern. So we may have to be careful about the person may have more confusion, drowsiness, some general weakness, and maybe even coarse tremor. That we have to watch for. Easily, if you discontinue one or both of the agents, that usually goes away. But it is something that when we combine those, we do get improved efficacy, but we also have a greater chance for neurotoxicity. The other thing that we have to be careful about is combination of lithium and carbamazepine may suppress the thyroid. So we want to monitor thyroid. So we could get some hypothyroidism. Lithium and haloperidol have been used together. The neurotoxicity, when we're talking about neurotoxicity, again, it's very similar. Confusion, drowsiness, generalized weakness, those type of things. One of the things when somebody is using some other drugs, now remember, whereas lithium doesn't go through the liver, carbamazepine does. So what we find is, remember the drug cimetidine, which is over the counter, erythromycin, very common antibiotic, the calcium channel blockers, verapamil, diltiazem, and fluoxetine, an antidepressant. Those can interact and elevate carbamazepine values. Isoniazid is used for treating tuberculosis. Um, the other thing we have to, so these type of drugs inhibit carbamazepine's metabolism, so we may get greater side effects associated with that. But the other thing is, remember that carbamazepine is a liver enzyme inducer. So this first bullet here is talking about really inhibition, is that these other drugs inhibit the metabolism of carbamazepine. The second bullet is dealing with induction, that we do know that carbamazepine can induce liver enzymes. So one of the things that may happen is it may cause antipsychotics, antidepressants. Phenytoin is another anticonvulsant. Valproic acid, benzos, oral contraceptives, even warfarin may actually be, their efficacy can be interfered with. One thing that we try to make sure people understand is sometimes they forget about oral contraceptives. So one of the things that may happen is somebody that's on oral contraceptive with carbamazepine may actually run into a problem where that they are basically not protected. So we many times will suggest they use something other than an oral contraceptive. And of course with warfarin, we have to be careful with the, if we decrease the effects of warfarin, basically the individual may be at a risk for clotting. Again, when we're looking at serum levels, they're actually based upon anticonvulsant therapeutic values, but we still use them because we are using dosages similar to anticonvulsants. And so that's typically what we're going to do is draw blood 8 to 12 hours after dose. And again, with a drug that's an inducer, we always have to be careful that after a few weeks that it may induce its own enzymes, so it may become less effective. Again, multiple drug interactions, which I showed you on the previous slide. Another thing about carbamazepine is that it does get metabolized to a toxic metabolite. The metabolite is an epoxide. It's 10,11 carbamazepine epoxide, and that can produce an interaction with valproate, lamotrigine, and phenobarb, and that is completely different than the carbamazepine. So one of its metabolites may actually account for some of the drug interactions that we have and potential toxicity. Now, we'll come back to oxcarbazepine, but this drug came out, and with carbamazepine, we saw it used for a number of things, but one of the big issues was we had a lot of drug-drug interactions, was more lab monitoring and adverse events. And oxcarbazepine actually came out, and basically people suggested that it might be equivalent to efficacy as the carbamazepine. We don't have as much data on it as we do with carbamazepine, but basically you're looking at 1 milligram of carbamazepine equals to about 1.5 milligrams of oxcarbazepine. But this was one alternative that was potentially proposed. Talk a little bit more about this in just a little bit later today. All right. So as I told you before, let's see, let me answer your question, Rebecca. Okay, so going back one slide and let's address Rebecca's question. All right, you talking about this slide about enzyme induction? So remember on the drug interactions. So what we have, so if we go back one more to this slide here. All right, so one of the things is carbamazepine is going to be metabolized to the liver. So since it's going through liver enzymes, other drugs that inhibit the liver enzymes that it's going to be metabolized by, if they're there, they're going to decrease the metabolism of carbamazepine. So what we get is the first bullet point here. These are drugs that basically interfere with carbamazepine's metabolism. So these other drugs are inhibitors, and by inhibiting the metabolism of carbamazepine, then carbamazepine concentrations can accumulate, they can increase, and we're more likely to have side effects, okay? Carbamazepine, its own actions is it will cause enzyme induction. Literally what it does is it stimulates the production of more enzyme. So as a result, metabolism is going to be enhanced. So that's why carbamazepine may lose its effectiveness, is simply because as it is metabolizing, being metabolized faster, then it's getting out of the system. But it's inducing these enzymes, which may also affect other drugs. So if the person is taking antipsychotics, antidepressants, valproic acid, benzos, oral contraceptives, or warfarin, those drugs, because of the enzyme induction induced by carbamazepine, actually are going to be metabolized faster. And so when you get those drugs metabolized faster, they get out of the system quicker. So as I was saying with the oral contraceptives, is someone may be taking an oral contraceptive, but it is being metabolized so quickly that it may not be as effective. So the first bullet point are the drugs that may increase carbamazepine levels because they're interfering with its metabolism. The second bullet point is referring to when carbamazepine induces enzymes, and by inducing the enzymes, basically it creates a scenario where that these drugs will be metabolized faster. And not only will those drugs be metabolized faster, but carbamazepine may be metabolized faster. Okay? Okay, great. All right, so we're at a good point to go to your case study. So I know we haven't covered all the drugs, and so you're at a little bit of disadvantage, but I gave you a case study last night. And so one of the things that let's do this, is normally we take about a 15-minute break. Well, I'm going to give you till 1/4 after, so that's almost 25 minutes. That's time for you to look over the case study. Hopefully you looked at it last night. And when you get back, what I want you to tell me is, let's go over what drugs what your plan would be. So in essence, you can think of doing a SOAP note, but we're going to really focus in on your assessment and plan for that. So if you guys will do that, and then at 1/4 after, when we come back, we're going to discuss this case a little bit. And then I'm going to throw a little bit of a wrinkle that you guys will need to address. Okay. So pull up the case study. I think Aiden had posted it last night. Look over it. Come up with what you think would be the way to do that. And at 10:15, we'll resume and we'll get your feedback with how you think on the case goes. Okay.
Dr. Just in case some people don't have access on their phone to the Moodle, I'm going to also upload the case into the chat.
Okay, that sounds good. Sounds great. Your case here a little bit. So we had Aiden put it up, 25-year-old male, bizarre behavior, vocal ranting, previous history of psychiatric admissions for acute mania. He was put on lithium. His lithium concentration is 0.1 milliequivalents per liter. Diagnosis was bipolar, current episode mixed. And so what I wanted you to do is to really give me some what your goals of therapy were and what your options were. So does anybody want to sort of chime in here with what we need to do on this patient, or what you think? So so Carmen, you'll start off with manage current episode of cycling. All right. Need to stabilize the mood. All right. Look at, okay, Arnold, you mentioned, take a look at his compliance. All right. Joy, you put rule out substances. And so we've got reduced mixed state, produced mood stabilization. assess his current medications. All right. Anything else that we need to do? All these are good. Much as history as possible. We've got what we can from this person at this particular point. And let's get through try to get this manic. There is a question of whether is he suicidal. We don't have anything that tells us specifically, although we know he's at a higher risk. So he has not admitted to being suicidal. Okay, so Kirsten brings up is dehydration. So that's an issue. We don't know where his family is, and we need to get some labs on him. All right. So anything else? All right, so let's move to, so we know that he has had some treatment because he's been on lithium. And we see that there's a lot of things, but pretty much what we're getting is only him. We don't have we have got normal values on his labs except for dehydration, and his white blood cell count is slightly elevated. Okay, so that's what we know. So let's move to Danielle. You've moved to the next state. All right, so he's been on lithium. So what is your plan with regard to is that? So one issue is his levels are low. He may be dehydrated. So one thing may be simply to just simply do an IV hydration, which should help. One issue may be to increase the lithium, rehydrate, and then if the infection is with his white blood cells slightly elevated, he probably doesn't have a raging infection that's contributing to it, but we might want to find out if that was a one-time thing. Find out if he was being compliant with lithium, okay? And Jason, you mentioned to be thinking he's not very compliant on the lithium, so maybe consider switching him to an anticonvulsant or adding an antipsychotic. Given the aggression, Brady's one issue is that there's a possibility of considering adding the carbamazepine. Janelle, you mentioned about potentially either carbamazepine or Abilify. Okay. All right. So any other drug combinations that you guys are thinking about? These are all good suggestions. All right. So here's what I want to do. So given some PRNs, Kirsten, there are some, when you're talking about antipsychotics, there are some available for injections. Risperdal, I believe, is IM is one of the ones. Okay, Haldol may be a potential. All right, so here's what we're going to do. So think about what your next step would be, okay, and sort of have that in your mind. And I'm going to talk about valproic acid, and we're going to cover a little bit more drugs, and then I'm going to we're going to give you another little break because I've got an update. So the idea is you will have put him on or made a change with whichever one you think is there. So that will be in your mind. So your choice would be whatever it has been. And these are all viable options based upon what we have. But then we're going to give a little bit of wrinkle because I'm going to say, okay, you've taken and started him on the one that you think should be, or modified his therapy, whether it's modify the lithium, add a drug, or maybe even swap him off a drug. So there's been several potential issues that are there. Okay, and so what I'm going to do is I'm going to throw another little wrinkle in here when the patient comes back to see you. So he will be compliant in the sense that he's coming back to see you, and then I'm going to give you a wrinkle on your next visit. So let's move on and cover some more material. And then when we take our next break, I'll give you this new stuff and you'll do that. We definitely want to be, and Arnold, that's a good point, is that from a standpoint of we definitely want to pull up, make sure we get new labs and so forth on him. And if you've chosen a drug like carbamazepine, obviously, you're going to want to do that. We want to rule out substance abuse. So those are good issues there too. All right. Okay. So let's move to valproic acid for a little bit. And this guy has, you've discharged this guy, and he's supposed to come back and see you in about a week. So that's your next plan is you've started whatever your therapy is, and he's going to come back in a week to 2 weeks as a follow-up visit. And then I'm going to give you the new issue to deal with when he shows up. Okay. All right. So let's move to the next drug that's used here, and a very common one used is valproic acid. Valproic acid, valproate, there's a lot of different things here, way that's identified, but it was originally came out as basically an anticonvulsant, and then in 1995 it was actually approved by the FDA as a mood stabilizer, specifically for the treatment of mania that's associated with bipolar. In the data and the information that we have, it appeared to be, let's see, make sure my pen. It appeared to be as effective as lithium in patients that had pure mania. So that was an important issue there. It was one of these drugs. If you see many of these anticonvulsants, they seem to be a little bit more effective than lithium, especially in patients with rapid cycling or mixed mania or even comorbid substance abuse. And one of the reasons comorbid substance abuse with the lithium, one of the concerns is it's just overall compliance and so forth like that. So what we saw with valproic acid was very similar to what we saw with carbamazepine. We saw that people that were rapid cycling seemed to respond pretty well. People that had mixed episodes where they had high levels of dysphoria or depression during the manic episode, they responded pretty well. People with panic attacks, people that, when we talk about organic features, there seemed to be an abnormal EEG, so something else may be going on, and even people that had history of mental retardation or head trauma. So those particular patients seem to respond well to valproic acid. We found that when you augmented valproic acid with another drug like carbamazepine, lithium, antipsychotics, or even benzos, we seem to see that the antimanic effects seem to be augmented, so it seemed to be better. I always have caution about benzodiazepines, especially if you're dealing with someone with substance abuse. But the other thing we saw with valproic acid is that it seemed to be anxiolytic, so it reduced some of the anxiety. We had people that had migraines, and the migraines seemed to work. In fact, we've used valproic acid to treat migraines. And it seems to have an analgesic property, which is probably why it works with the migraine. So it decreases the pain response. So valproic acid was sort of an interesting drug that moved and seemed to be, has some promise here. The mechanism of action is believed to involve a lot of different things. We're not really sure exactly. This is always when you see if you read the package inserts and under the pharmacology, there's a statement that says so-and-so may do this, this, and this, and then it says the exact mechanism of action is unknown. This is typically what it is. There's several things that have been proposed that suggest that could potentially account for some of the effects. So one of the things with valproic acid, it seems to be somehow associated with an increased level of GABA. It's believed that one of the things that happens is that, excuse me, that basically the valproic acid may inhibit the breakdown of GABA, so therefore this inhibitory transmitter stays active longer. And it may actually potentiate, so when the GABA binds to the receptor, that receptor interaction seems to be enhanced. So so we got two things that may be happening is keeps the GABA around longer and seems to make it work better on the receptor level. There is also an action on potassium channels, and when we affect the potassium channels, that can affect the sensitivity of the cell or the electrical activity cell, so that could fit in there too. And as far as an anticonvulsant, and this could possibly work with regard to some of the mood stabilization is it seems to have a membrane stabilizing effect. So it makes it more difficult for the neurons to discharge. So these are all proposed, but the exact mechanism we don't really know. All of these could go in. You've got, with bipolar, it could be that you're basically stabilizing the membrane, you're enhancing the effects of GABA. That would all account for many of its anti-manic type effects. Initially, they start the dose 250 to 750 milligrams per day. If it's a small child, they may go by weight basis, or if it's a child in general. They adjust the dose about every 2 to 3 days. And what we do see that if the patient was acutely agitated in mania is they may use, around 1,200 to 1,500 milligrams per day. So that's the dosing. And again, I'm not going to ask you a specific dosing thing. Now, valproic acid has a half-life of about 8 hours. So especially when we're dealing with an anticonvulsant, and the reason I mention the anticonvulsant actions is simply because several of these anticonvulsant drugs, the dosing and so forth, is based upon it being used as an anti-seizure medication, but we're going to still use some of these principles for bipolar. So one of the things is that since it has an 8-hour half-life, especially if you've got someone with seizures, you are pretty much wanting to maintain pretty stable concentrations. If it drops too low, you're going to potentially activate a seizure. But we're not talking with patients with seizures. We're talking people with mania. So typically, what we see is that a lot of times it's given up to 3 times a day, so every 8 hours. We don't know the therapeutic plasma levels for bipolar patients. Those have never been established. Most clinicians will target what we've seen with anticonvulsant plasma levels, and that tends to be between 50 to 150 micrograms per mil, again measured 12 hours. Not going to ask you these plasma level ranges, even though it's in red, but what I was emphasizing on this was basically you're going to measure it 12 hours after the last dose. So if they take the last dose, let's say they take a dose at 8 in the morning, and then they take another 8 hours, and then another 8 hours, basically you're going to be looking by, if you take it before the next dose at around, they come to the lab first thing in the morning, then basically we should be fine to pull the blood. We see that people have tried to go above the 150 micrograms in patients that were resistant. And so even though the efficacy is there, the incidence of side effects just outweigh its benefits. So it's very difficult to do that. Now, one of the big things we see is that valproic acid is that when you give it, one of the big things is it can be irritating to the stomach. So that's been one of the things. So one of the things that they've done is that they've given, instead of giving valproic acid, they give divalprox or valproate sodium. And that dosage form appears to be less irritating, because what happens is it gets converted in the stomach, or gets converted actually in the small intestine where it's going to be absorbed. So that's one way to get around it. The divalprox is basically used to be less irritating to the stomach. Kinetics, one of the big concerns we have, well, first of all, it's pretty rapidly absorbed, so it gets in pretty quickly. We do use sometimes, with the valproic acid, we have the enteric coated tablets. They look like the Skittles. They look like the candy shell on the outside. Those basically are designed to protect the stomach, and it takes a little while for them to be absorbed. So you see that the absorption is delayed about an hour when you use the enteric coated tablets. But the biggest thing that we see is that it's highly protein bound, which means chance of drug interactions due to protein interactions. And we see that it's metabolized in the liver. So what we find is that we have to worry about this drug specifically with regard to the actions. Maribel, you asked about what is Depakine. It's a form of valproic acid. So it's actually valproic acid. When you look at it, there's a few different forms with it, but it's the same thing. So now the half-life, as we talked about, an 8-hour half-life is assuming an 8-hour half-life. The half-life is the lowest would be around 8 hours, but it can be 9 to 16 hours. Typically is what we see. So typically it's going to be dosed generally 2 to 3 times a day based upon the half-life. So there are some contraindications. Now, let me state what I've said before. When we talk about contraindications mean you shouldn't use the drug. But there are times when drugs are used in a contraindicated patient or in a contraindicated situation because there is no additional, there is not an alternative. So in this case, the prescriber has to make a benefit risk assessment. And by making that benefit risk assessment, you then are going to make a decision on, and if you do use it and it's considered contraindicated, what you're going to do is you're going to monitor that patient very, very closely. But one of the big things is that we have to be careful about is in patients that have severe liver disease or liver dysfunction. Since it's metabolized through the liver, if severe liver disease can create a major problem by creating toxicity. And then if somebody happens to be hypersensitive to it, that's a standard contraindication for almost every drug, hypersensitivity to valproic acid. So there is a black box with valproic acid. It starts off that there are life-threatening adverse reactions. That is one of the big bold things there. So one of the things that is a concern is that valproic acid can cause liver damage itself, okay? Actually can cause liver failure. So if a person already has liver disease, you're going to be giving them a drug that in itself, the toxic effects may cause liver damage, or even liver failure. The group that's at increased risk are children under the age of 2. We see this, obviously, we're not going to be treating bipolar patients that are under the age of 2. This is primarily because of it was used as an anticonvulsant in this group. But older people can also be at risk for hepatotoxicity. Typically, it's going to occur within the first 6 months of treatment. So during that first 6 months, if you are even concerned, we're going to definitely monitor liver enzymes in these patients, even if they're even if we're not dealing with children under 2. We want to get a baseline. We want to make sure that there is no issues that are kicking around here. There are some neural tube defects, so we want to avoid this. There is a fetal risk. We want to avoid this in pregnant women. And it also has been shown to produce a pancreatitis, okay? So that's an inflammation of the pancreas. And this is, the severity of pancreatitis is the pancreas contains all these enzymes. So when the pancreas gets inflamed, as it gets inflamed, it starts digesting itself because the inflammation destroys and releases these enzymes that the pancreas normally uses for digestion. Or that secretes for digestion. So this can be life-threatening, and it can occur both shortly after initiating therapy and also after chronic therapy. So any signs that we're seeing where people are having pain or anything like that, it's something that we want to pay attention to. This is the hepatotoxicity we've already talked about, but the only thing I've added here is on this slide that's different from the other is typically what we're wanting to do here to monitor this is to perform liver function tests at baseline and then especially at frequent intervals during the first 6 months of therapy. After that first 6 months of therapy, we can spread things out a little bit more, but probably you're wanting to monitor this maybe at least monthly. Definitely, you don't want to go 2 to 3 months in that, but you might want to get baseline and then within a month, and then also, the patient reports any signs of liver dysfunction, which can be a wide range of things. We do see, these are in the old label, they were under precautions. One of the things that's changed about the package inserts is the new package insert format just has warnings. It doesn't have precautions and warnings separated. We do see that this can have some hematological toxicity. Thrombocytopenia can occur, so we can get platelet drop. So what we want to do is monitor platelets, looking at bleeding times. Does anybody remember the test that we get to, so we can get a CBC that can give us platelet number? What is the, when we're looking at bleeding times and things like that, do you remember what the test is that we require or that we request? INR, right. INR is basically the normalized, it's the international normalized ratio. So the INR is what is requested. If you requested a bleeding time, they will send you, or prothrombin time, they will send you, they will report it as an INR. Okay. We want to get that before therapy. And also, as we've mentioned before, things that you look for specifically is whether there's been any bruising or hemorrhage or things like that. That may result in either reducing a dose or sometimes even taking them off the valproic acid. Now, here's a unique thing. I've had one case that I knew about hyperammonemia. So this can occur even when there is normal liver function. And this can come on. So the patient may, normally when you get hyperammonemia, normally your liver is normally ammonia does not build up. Your liver breaks it down pretty quickly. So the valproic acid can actually create a problem with regard to the elevating ammonia levels. And if this occurs, basically we need to discontinue the drug. And usually it is a dose-related effect. So the higher the dosage that occurs. And excuse me. So Joy, you would see typically lethargy is what you commonly see, but there have been some cases where individuals, the ammonia levels just shot up there. And so the first sign you saw was them going, into severe decline. So one of the things, typically you will see some neurological symptoms, but sometimes this can occur so rapidly you don't see it progressing like you would see with someone that was having liver damage, where the ammonia was continually slowly building up. And let's see, Janelle, you were asking about L-carnitine. Let me see, I was checking to see. Yeah, I'll come back. I'll hit that. I thought I had a slide in here on that, so I'll hit that in just a minute. So getting back to, the other thing is with the hyperammonemia, a lot of times you will see that, but the biggest reason it says may occur with or without lethargy or coma is because it may elevate really quick and somebody may actually have that. That voice, I don't know if it's breaking up, but if it's like sounding sort of weird, I think it's my voice more than the mic, unless it's not doing that, but I'll move closer to the mic. So, so I'll come to the L-carnitine seems to decrease the side effects. I'm not really sure from Janelle with regard to the exact mechanism with that, but that has come up as a suggestion, and we'll talk about it in just a minute. Typically, your biggest side effects you see with this drug is it's usually pretty well tolerated with the right patients, that you don't have any of the things that we were presupposed to. Most common effects are gastrointestinal, upset stomach, nausea, some indigestion. Sometimes people will have some cramping or pain that's in where the heart, right here around the mid-sternal area. This, a lot of times, we tell people to take the drug with food. That helps. use lower doses or use one of these delayed release products, one of the enteric coated products. We do see some sedation, some ataxia, some fine hand tremor, lethargy. Those have all shown to occur with valproic acid. And again, the GI effects are there. Now, what some people will complain of is that they lose their hair. And if they don't lose their hair, what they'll may see is that the hair seems to change color, and the texture of the hair seems to change. And that sometimes can be enough of an issue for them not wanting to take the drug, even though obviously it's not life-threatening. When I see alopecia, it's always funny because if you guys remember Fen-Phen, excuse me, one of the things that we were complaining about, I was an expert for Fen-Phen for the plaintiffs, and one of the things was that they said that they delayed in putting on the valve problems, and said they were waiting to get enough data. But interesting enough, the company, with just a few reports of alopecia, made a label change. So we're sitting there going, so it is a more life-threatening situation if you lose your hair than if you develop hard valves. Another big thing with valproic acid is that we often see weight gain. And so that is a concern with some of the patients, and they will may be enough for a compliance issue. Several drug interactions. We always have to worry about, this is a CNS depressant, so any other drugs, including some of the other anticonvulsants that we may use, can produce too much sedation. We do see that there may be a drug interaction. Valproic acid is protein bound, and we can see that the valproic acid will bump off the carbamazepine, and when that occurs, then you actually may get some carbamazepine toxicity. We don't want people taking aspirin. That's been shown to elevate the valproic acid concentrations. And good point, Joy. And here's another thing. This is one of these drugs that can interfere with lab tests. So one of the big things you have to worry about if they're on valproic, it can actually produce abnormal thyroid tests. So what you want to do is that this would be a situation where that the person doesn't have any symptoms of thyroid disease, but their lab tests indicate there may be thyroid disease. Also, it can elevate urine ketones, which may give you a concern with diabetics. You may be concerned that they're, that they're into that. One of the big things that may happen is with people on the ketone diet, on the, going on this ketone diet, is that this can be an issue that comes up too. And then carnitine or selenium has been suggested to reduce the side effects. I don't know if there's any hard data for that. I think there's been some anecdotal data that suggests this, but I don't know if there's been a study. I would have to look back. But there are people, since carnitine or selenium, we have seen people that basically use it and say it works. All right. Let's go to, we're going to take our break, but I'm going to give you a few minutes. So here's what happens. You got to go back to your case study. And Aiden, go ahead and put up the link if you haven't already done it for that. So what happens is your patient comes back in about 2 weeks, and you're happy that he's compliant, that he's come back. This is the same one we've talked about. But what's happened is, while the 2 weeks he's been gone, he has found this video from a psychiatrist that he is concerned about now. So he actually brings you the link. So what I want you to do is, before we talk about lamotrigine, is I want you to pull up this video. I think the video is 9 minutes. And so if you will we're going to do a combination break video. Look, so I want you to pull up the video. Aiden will have the link for you. If he hasn't already posted it, he'll put it up. Watch the video. It's 9 minutes long. And then I want to know how you're going to respond to your patient when he's watched this video. Okay? So being that, let's come back at 10 after the hour. That gives you 10 minutes to watch the video, think about it, and also take a quick break. All right?
Doctor, I'm going to also run the poll right now, and the video is on the Moodle.
All right. Thanks, Aiden. I'm going to mute here. Aiden, can you post the link to them maybe on the chat, and they may not have to log out and go to Moodle?
Sure, I can also put it here.
Okay. But that'll help with you, Rebecca. Point, some of you made some comments with regard to this. So what would you say is, how do you address this patient? So they come back and they come back after they bring you this video and say, you know, I've got some concerns with what you're saying. So what is your how do you address the patient with that? Because I'm sure many of you may have had patients that come back where they've gone on the internet, gone on YouTube or whatever, and come back with regard to come back with things that they think is either better or things that they are arguing you shouldn't be doing. So how do you address this patient from a standpoint with regard to him showing up with this? Contact Tom Cruise. So, you know, really the whole thing is the issue becomes that, first of all, you guys know this, and this is an interesting, I've done this a couple of times with regard to several classes, different healthcare professionals, and you would be surprised. Now, you guys have actually thought about it, is that basically, you know, you're sitting down and you're going to have an honest conversation, and while you're particularly recommending things, you know, the individual becomes what you see sometimes is, I've seen this with residents and some of the others, is sometimes when people come in, they've never even thought about it. And part of their approach is just to say, well, this guy doesn't know what he's talking about. But, and that may be the case, but to the patient is selectively hearing for some reason what they want to hear. And so, you know, it's an issue with regard to sitting down and talking about that. Now, Brady, I actually, I tell my students to do this a lot. It's interesting, is and I do this in law cases, is I tell people I'm going to take and actually act as if I'm working on the other side. And sometimes by having them look at the other side of the argument is to help them sort through that. But one of the things is that, you know, it's really sitting down and so I always try to tell people is, first of all, try to talk yourself out of why you're going to prescribe drugs. If you can easily do that, then you should really consider whether you need to be prescribing anything. But the second thing is basically, if you get into just saying something like, I've seen some people that just go, well, that's a bunch of hogwash, you know, it's on the internet, you can't believe it. The patients may get very defensive. So what you may end up doing is basically, I mean, people spend things differently. Joy, you made that comment, but and he comes across very polished in the video. So a large part of it is sitting down and not so much criticize, in my opinion, this is my opinions, a large part of it is not to sit down so much and criticize the patient. I mean, to criticize the video. I think the issue is that you build the case to and get the patient to understand what you're doing, and that video is a generic video. So the point becomes is like some of the things, talks about serious side effects. We all would agree that all drugs have side effects, and that probably find, think about this, people die from overdose of aspirin. Okay. That's, by the way, been one of the big arguments with marijuana is safe because people don't die from it, but they die from aspirin. But the thing about it is basically getting the patient to understand and giving the patient some degree of your rationale with regard to that. The way you're approaching what you're going to do is to try to minimize those side effects. You are aware, you have been trained, you have experience with these drugs, you have experience with patients on these drugs, and you have certain precautions that you have in place to address that. And one of the things is that, and I do not have any, I'm not familiar with him at all. I mean, I've seen his videos, but I do not know him. And, I think the issue becomes is that when patients bring you this stuff, from wherever they've gotten it from, Cosmopolitan magazine, or whatever, I think you have to sit down. You will find that, I mean, I have had situations with regard to clinicians saying this is the way it has to be, and I think you can't be that way because every patient is different. I've seen some clinicians that have approached it this way, is like, this patient this guy has not examined you. He does not know you're on, all the things I have. I've got all this data. I'm collecting all this data so that I can personalize this medicine to you. So, we know drug, one of the things I tell students all the time, getting to your comments, Jason, is basically drug companies are businesses, and drug companies are there to make money. Yes, the way they make money is to, quote, help people. But the point becomes is the drug company is not treating the patient. You're treating the patient. And that's an issue with regard to it. I saw this really sort of what you saw, Jason, is more of as an ad for pushing his book. And the point becomes is that we're pushing in general sort of a holistic approach to treating the patient, which is we want counseling, we want lifestyle changes, and we're going to use drugs. We're going to use minimal drugs as low as we can to get the effects. And by doing these other things, we can do that. So it's really just be prepared. And the reason I wanted to give you guys this situation is for you to be prepared for someone to show up in your office with something like that. Some of you may have already gone with that. And, you have a lot of people that come on. We see these on TV all the time. People will listen to a Dr. Phil or a Dr. Oz, their generic statements, which they pull out and try to apply it to their particular situation. And it may not always be there. So this unfortunately does happen. And I gave you this one mainly because just to see how you'd react to it. That old adage that it's got to be true, it's on the internet. There are people that believe that. There are people I've come across, and I do a lot of CE programs, and I do a lot of programs for, with parents and stuff like that, and different groups. And you would be surprised the number of clinicians and or patients that come up to me that are believing because it showed up in Prevention Magazine or Cosmopolitan or Men's Health, and various places like that, that it's almost like it's major. A lot of these places, magazines like Men's Health, Prevention, the writers are actually doing their interpretation or their summary of clinical trials and things like that, but it does come up too. So just be aware of it, and I gave this to you for you guys. Again, this class has shown me a lot that you can handle these type of things with regard to it, and a large part of it is trying not to spend all your time criticizing the video, but really get the patient to focus on what you're doing for him and how he can be there. Okay. All right, so let's move on. And so what I want to do is try to cover lamotrigine, and then we'll break for lunch, give you your quiz, and let you break for lunch. And Jason, I sent you an article, I think. Aiden, I sent you an article on drug interactions, I believe. Have you? If I didn't, I will send it to you. But go ahead and post that so they can look at that at lunch. Okay. All right, so let's go on. Let me move my little chat session to the side. You guys were quite chatty today, I've got to tell you, and good comments. I appreciate it. All right, so lamotrigine. This is one of the drugs, in my opinion, as I've seen some of the approval issues, and in many ways I was surprised that this has been approved. But basically, lamotrigine or Lamictal, actually in the 90s was when it was actually investigated for mood stabilizing. And in 2003, it was actually approved for maintenance of bipolar. One of the big advantages of this was that it was minimally sedating compared to some of the other drugs. And it seemed to be effective for the depression part, whereas a lot of the other drugs we had seemed to be more effective for mania. That's a big issue that we see, is that with Lamictal, I think one of the big pushes was many of the other drugs we had were more effective for mania and minimal or variable effects on the depression aspect of it. It is an anticonvulsant, and what we believe it does is the mechanism of action is it stabilizes membranes. We also see that it decreases the excitatory amino acids. Most of these are associated with this anticonvulsant action, but you could see where that these effects could also be effective in the depression. And then it can also block sodium, calcium, and potassium channels. So again, its exact mechanism of action as in bipolar or mood stabilizer is still unknown. One of the things with the lamotrigine is that when it was released, there were actually when it was approved, there was relatively small number of trials done compared to a lot of the other drugs. In one of the trials, basically they had a response rate of about 48% with depressed presentations and about 81% with manic, hypomanic, or mixed presentations. There was no placebo-controlled trials reported early on. And there was when you actually look at the clinical studies, there is a suggestion of an effect, but that was one of the things that surprised me in looking back at Lamictal, is with its approval, it just did not have the robustness of trials that you would expect it. The major issue with Lamictal that has emerged is serious skin conditions, rash. One of the things is that, and the black box warning talks about this, is that you need to slowly titrate the dose up. And if you're combining it with valproic acid, you need to reduce the dosage. So the biggest thing when I've seen med-mal cases with this, where people have developed Stevens-Johnson syndrome, what I've seen is basically individuals that have escalated the dosage up quicker than what's been recommended. So even though the black box will say it's not proven that escalation of dose does do that, or some verbiage, something like that, we have seen that, and that usually is an issue. So starting slow and following the recommendation has been been what most people strongly suggest. It does, as I said a moment ago, appears to be more of an antidepressant. with people questioning how effective it is as an anti-manic agent. So the black box of Lamictal, you've got serious skin reactions. Most of these have occurred within about 2 to 8 weeks, so in the first 2 months of initiation. But there have been individuals that have been on the drug for a while, like for 6 months or so, and have developed it. So you can't just say you're out of the woods and don't have to worry about that after, you know, the first couple of months. With any of these rashes, just like what we mentioned before, if the rash develops, you should discontinue Lamictal unless you know it's not drug related. Your patient comes in and is broken out in a rash, and you find out that, you know, they were working in their garden this weekend and got into poison ivy. But if you're unsure, probably the safest thing would be to discontinue the drug. We do see drug interactions. So again, since the rashes or serious skin reactions can occur, we've got to be careful. Valproate will increase the lamotrigine levels. So if we're using the combination, we got to be extremely careful, slowly titrating up. Carbamazepine it decreases it because typically you're going to get the enzyme induction. So the first one, the valproate, is an enzyme inhibition issue. And the second one is the enzyme induction. Maribel, on the Lamictal or lamotrigine, it doesn't appear to be as suppressing, but you can get some cognitive dulling depending on the dose or in some patients. Now, there has been, since anticonvulsants, carbamazepine, valproic acid, and lamotrigine, those have all been sort of thrown out as being anticonvulsant. Many other people have thought that if it's an anticonvulsant, then it should be useful. So there's been a number of drugs that are anticonvulsants like gabapentin, pregabalin, levetiracetam, tigaban, topiramate, that have been tried in the treatment as mood stabilizers. The really aspect of it is there's never been any proven efficacy there. What we do see sometimes is some of these drugs may have other properties that may help with some of the side effects that may come into, but as far as standard mood stabilizers, you will have a few clinicians that will say, I've used these others and they work pretty well, and they still use them. Typically not as monotherapy, but in combination with other drugs. Gabapentin, it's a structural analog to GABA, so very similar in structure to GABA. There's been 2 controlled trials that have been published. It was not as effective as lamotrigine and actually showed no more effective than placebo. So from that standpoint, it doesn't appear to have any significant mood stabilizing properties, although you will see it used sometimes there. Topiramate, so topiramate basically is another drug which enhances GABA activity, and it actually antagonizes the non-NDMA receptors. There was one small study that's been done and that suggested some benefit, but again, not a very robust study. One of the big things why topiramate is used gets down to this third point here, okay? Is what we think is happening here is topiramate, you know, weight gain is a big issue with these other anticonvulsants. And so one of the things that we find is people add topiramate in, and what we see is that helps reduce the weight gain. So probably topiramate, whether it has a mood stabilizing effect is really still up in the air. But we see topiramate being added because if it does have a little mood stabilizing, that would help. But probably its biggest benefit is falls into the category of primarily reducing appetite and decreasing weight gain. And again, still questions. Some side effects that we see. Sometimes now we may get weight loss. So too much weight loss may be there. We can get some cognitive dulling with this, and we also see some potential with kidney stones and some metabolic acidosis. But typically the biggest thing is that we may see some cognitive dulling when this is added with it, but most frequently its main benefit is probably to prevent the weight gain. And let me cover this last drug here, and then we will give you your quiz and send you to lunch. So oxcarbazepine, never used as monotherapy. Again, its efficacy is questionable. It's really not substantiated. So the biggest thing, it's very similar to carbamazepine structurally. It's actually an analog of carbamazepine. And the biggest thing is that it has less drug interactions and fewer side effects. One of the big reasons is, remember, carbamazepine has this toxic metabolite, oxcarbazepine doesn't. Typically, you're going to need a higher dose of the oxcarbazepine because the carbamazepine is going to be having the parent compound and the metabolite working. So it takes a little bit more with regard to this. And Jason, I've seen some of that data too. And again, it's been sort of more of anecdotal type information there. And let's see. All right, so let me cover this one other slide and then we'll stop. So we have some three new mood stabilizers that have come out. Levetiracetam, which is Keppra. The big thing with it, it had very few drug interactions. As far as how effective it is, it doesn't appear to be really, it hasn't been substantiated as a good bipolar mood stabilizer. Zanasamide, again, a lot of, there may be some effect, it's really not been substantiated. And then the last thing, which is, I've got it as newer, it's been around for a while, is this combination therapy. So what we've seen is that people thought, okay, let's combine an antipsychotic and an antidepressant. And Symbyax has been done, so you're getting the benefit of an antipsychotic, an atypical antipsychotic, and a SSRI. The biggest thing with Symbyax is that it's these fixed doses basically limit you to, what if you need a little bit more of the olanzapine or the fluoxetine? It's hard to adjust the individual components there. Typically, these combination products were more expensive. They can help, and sometimes when there's a compliance problem, but I don't know if any of you have seen Symbyax used, but a lot of times when I've seen it used, it's basically they give it and end up tweaking it with one or the other drug. So let's stop here. We will finish up. We're going to go through a few more things with this and then finish up with the drug interactions after lunch. So Aiden, if you will go ahead and give them their quiz. And then also, do you know, Aiden, if I've sent you that drug interaction paper?
I haven't seen any, I haven't got anything after the video link you sent me.
I'll just resend it, and if you'll post it on Moodle for them, they can look at it. All right, guys, go ahead and we will go over this quiz at the end of, at the beginning of the next session. And you guys have lunch, and I will see you at 1 o'clock.
I'll leave the poll going for 10 minutes.
Sounds good.